Ladies and gentlemen, welcome to our AFOMP School webinar for April. I think we have been running this webinar for more than 3 years. Great, today we have this school webinar. First, I would like to introduce our account. So Professor Account is the adjunct doctoral fellow of the University of Western Australia. He's been studying in his PhD in the medical physics at the Marina Scotland Curie National Institute of the Oncology. He got his master in medical physics at the Golden University, Bangladesh, at the National University of Bangladesh. Currently, he is the chief medical physicist at Evercare Hospital, Chattogram, Bangladesh, and the guest faculty at the University of Colombo, Sri Lanka. A membership of the undergraduate and graduate students. Also served as the president of Bangladesh Medical Physics Society. Also served as the editor of AFOMP House, a member of the ETC of AFOMP, the editor of the SCMP ASEAN newsletters, members of Science Committee of AFOMP, a member of AAPM, SCHOOL, Bangladesh Medical Physics Society, Bangladesh Physical Society, published more than 10 scientific articles in the international journals, and has been the reviews of the several international medical physics journals, received several international awards. So very brand biographies. So let's welcome Dr. Akhtar to moderate our today's small webinar.
Thank you, Professor Jean, for your nice introduction. Ladies and gentlemen, welcome to today's AFOMP schools. And today we have three distinguished experts in the field of medical physics. And the first speaker is Professor Hasin Anupam Azhari, and she is currently a professor at the United International University. She is also the Vice President of AFOMP and the Director of Center for South Asia Center for Medical Physics and Cancer Research. She has received her PhD in 2011 under the joint collaboration with the ICTP and DART scholarship. She has extensive professional work experience, more than 25 years, including Gono University, United International University, and more. She is very much involved with the professional activities. She was the founder president of Bangladesh Medical Physics Society, and she is the honorary doctor of the South Asia Center for Medical Physics and Cancer Research, executive member of OWSD, and many more. She has more than 70 scientific articles, conference proceedings, book chapters, and so on. She is the member of the AMPI, BMPS, OWSD, ESTRO, AAPM, and many other international societies. She has received Outstanding Medical Physics Award in 2020. She also have received IDMP Award by IOMP in 2018. She has received the Best Paper Award and the Best Journal in the Physica Medica. She has many more honors and awards, like the member of the Accreditation Committee, IMPCV, Medical Physics Journals, and she has the research interest in artificial intelligence, brachytherapy, radiology, cancer prevention, screening. Now I would like to Professor Hasin Anupam Azhari to deliver her speech. Please, Professor Hasin Anupam Azhari.
Thank you, Dr. Jean and Dr. Akhtar. Am I audible? Is it okay?
Yes, please, madam. Yeah.
Okay. So we just, you know, that's the AFOMP is doing very good webinars, the school webinars as well as the monthly webinar. And so we are happy that many more participants are interested to see this. So I am just, I will state today the radiation omen. Where is my slide? Okay. Just a minute. Can you see my slides? Hello?
Yes, ma'am.
Can you see?
Yes, ma'am.
But I can't see here what's happened. Just a minute. I'm sharing again. So I will talk about the medical physics contribution to the women's health and radiation safety. So before starting this, we must think that we must acknowledge our first women medical physicist, Maria Skłodowska. And you know that she was the first specialist to introduce principle of physics in medicine. And she has done a huge work and for which she has received the Nobel Prize. And she's also not only physicist, also chemist, and two radioactive elements, the polonium and radium. For this, she had given in the Second World War, which is generating X-ray using and make a radiological car. So from that time, there was no concerning of the radiation safety. That time with 1903, she has received the Nobel Prize. So for these things, the radiation safety comes after she has used these things. There are many radiation effects has seen and this have done that different organizations has write the many protocols for the radiation safety. So here you see, when we see that's the medical physicist, you all know the physical principle used in the medicine. So here the MPs are used. Many things are we are working here. We all know that we work in therapy, in nuclear medicine, in diagnostic radiology, not only that in lasers, physiotherapy, as well as in physiological measurement, medical instrumentation, and telemedicine. But in our following experts will speak on different area because when we work, we can work together in whole department. As a medical physicist working, if we have a license, we can work on also radiotherapy, radiology, and nuclear medicine. So we have to know all the three things together. And here you see here these slides. That's the you see here 76% people work in here in distributions of different disciplines. Just a minute, I just stopped the share because I think this is something is wrong. Just a minute. I'm again sharing. Now we are very capable that we are now full recognition of the medical physics. And this is the fruitful collaboration work between IEA, IOMP, and World Health Organizations. And this is, you know, that's in 2008, we have recognized as a medical physicist as a specific manpower works in these three areas, and this license we have got from the ILO. So why we are so much concerned with radiation safety? So I will talk after this only for women, but you know that's the X-ray is such a this every year 3,600 million people are going under this. In nuclear medicine, 37 million. In radiotherapy, 7.5 million. Not only this, the global population is increasing. So you know the technology advancing, also the technology more will be used. So we have to think always the radiation safety and to minimize the risks of the patients and staff. And this radiation in medicine, of course, enables our earlier diagnosis and less invasive treatments for the things. So medical physicists, when work in the companies, in the vendors, what we call in everywhere, we are also is relevant to the inventions, to creations. Then when after inventions, we do the assessment, also the update and the circulations. So when we'll do something for invention or something for the physics applications to the medicine, we must, during development and any technology, we must keep in mind that safety use of radiations, maintaining the quality, optimality, and consistency of the clinical practices. So this is the very important thing. Whenever we do something or whenever we circulate something, whenever we, as a like an entrepreneur, as a like a vendor, when we are working, and when we are using as administrators or as a medical physicist, we must think how much the radiation is going on and how we will keep the safety one. So here you see, this is the left side, this is the radiation spectrum. So in the lower energy radio-wave, microwave, we do not care about the ionization. But when it is come after the ultraviolet ray, we have to think about the ionization because it kills the cells. So we must work that we would like to kill the cells, but the tumor cells, but also we use for the diagnostic. So there are so many effects is going on, long-term effects, acute effects, short-term effects. There are many effects is going on that is very important. So when we will do three kinds of exposure, many kinds of exposure is there, I will show you. But first we have to think when we are working, then it is the occupational exposure. And that time we have a very higher risk. Because if there is we have taken more radiations, there are some short-term effects like radiation sickness or acute symptom. But sometimes the long-term effects, what we call the stochastic effects, that will cause the cancer, even genetic changes. So we have to very much careful when we'll do this exposure, we'll take, and within the exposure, when we work, we must think what are the immediate and long-term effects, and we have to be careful about that. In the medical exposure, in the common medical condition, because there are two ways. One, the women's coming to the as a patients and women as a worker. So normally in the as a patients, they come as a breast cancer, gynecological cancer, and osteoporosis. So we have to keep in mind when we are giving for diagnosis or treatment, there must be a radiation safety measurement. And when as a we are worker, then we have to think if it is in childhood, in the reproductive years or something. In case we know that in females are more susceptible to men because they are more have superficial and dominant breast tissues. And in reproductive years, we have made concern because there is a fetal irradiation caused inadvertent measures, as well as it is also caused the risk of genetic damage to their eggs. So here, these are the things we normally women undergo: X-ray, CT, mammography, ultrasound, and MRI. But when you know that the ultrasound MRI is non-ionizing radiation, so this is not a harmful. But in case of X-ray, mammography, CT scan, so we have to ensure very clearly the proper dose monitoring, which in turn make the safety for the patient for the lasting imaging procedures. So now what kind of exposure we can go through? One is the planned exposure, one is accidental, occupational exposure of the reproductive capacity. So when the doctors advise us to do something for the X-ray, CT, or radiation therapy, so these are the planned exposure. Even in cardiac catheterization, when we know about the valve functions, implants screening, interventional radiologies, so in many, these are the planned exposure. So occupational exposure, when we are working as a medical physicist, even with the technologist, the women technologist in radiation therapy, nuclear medicine, there are many more. So they have the occupational exposure. So radiation exposure, when there is a radiation exposure, we have to think about the increased cancer risk and genetic mutations. So potential risk, when we think of any person, so what are the potential risks we depend? This depends on various factors like age, health status, which radiation we are using, and what amount of radiation we are using, how much we are giving the radiations. So this is the very important to minimize the radiation exposure. So when we think these things, we must about these things must be clearly in mind. Actually, we would like to kill the tumor cells in the nuclear medicine or in the radiation therapy, or for the diagnosis, we need very good quality of image. So we know if we give the more dose, the image will be very good, but we should keep in mind what will be the effect on the behalf of radiation safety, what is going on. So this is very important for this, the risk assessment and risk management and risk communications. So risk assessment, you have to know it's the wound seer. They said we will use the radiation in the healthcare, but we have to know the dose distribution, population dose distribution. And for if there is a risk, we should know the risk management. So promoting how the radiation protection in healthcare setting, we should be promoted. Unnecessary exposure, we should be reduced. Addressing the whole health workforce with the medical use of radiation and prevention the accidental and unintended communication. And third one is risk communication. That means we have to make a communication strategy and tools for the risk dialogue for healthcare providers, patients, and caregivers. So this is the deterministic effect. That means by the dose. What we say that when there is a genetic damage, that is stochastic effect, the long-term effects, but in the deterministic effects, you see in every way, unless you see here the after 30 weeks of gestation in the pregnancy, only does there is not likely any produce of the gross structural abnormalities. But from the first trimester to the last trimester, 2 to 3 weeks, severe abnormalities, as well as in 4 to 11 weeks, many organs abnormality, 11-16 weeks are skeletal, genital organ abnormalities, 8 to 25 central nervous system effect. So you see here all the weeks of the whole pregnancy gestational period, there is some abnormality except after 30 weeks of gestation, but sometimes there is in 30 weeks of the gestation, there will be functional disabilities. So what we think that many females every week going to expose to the radiation exposure, maybe thousands of pregnant women exposed to the ionizing radiation. So what should be our guidelines? The guidelines is when there is a worker as a worker in occupational exposure, we have to inform the employer as soon as the people are pregnant. And also we have to think that we take minimum exposure with how by the time spent near the radiation source. When we'll do work, we wear the protective equipment such as lead aprons or thyroid shields and avoiding direct exposure to fetus by changing any positions. So now you see here when there is any abnormalities, we can terminate the pregnancy. So the normally spontaneous abortion is more than 15% spontaneous abortion occur. So you see here if it is the more than 100 to 500 day, so that time is not so much effect, but high fetal dose like 100 to 1000 milligram. Late pregnancy, no malformation or birth defects occur. And for life-saving or emergency procedures, we need exposure may exceed 0.5 millisievert to a large population of the body. So this is what we tell is in a graph. You see the advanced trimester, the effect is reduced, but in the early trimester, there is even prenatal death, congenital abnormality, neonatal death, and leukemia. So radiation-induced malformation usually occurs in the 200 to 200 milligray or higher, and even intelligent quotient and 100 milligray can result in reduction of IQ. So when we will do something for the pregnant patient or pregnant occupation people, then we have to think what can be happen, and we have to monitor, and we have to know how to make it less exposure. So when we, as a health worker, when we work, we should use the monitors. That is active monitors or passive monitors, and also the radiologic technologist or radiologic assistant must use lead apron at the waistline where a monitor. And active monitors is very good because this is real time, and when there is a excess of radiation they are getting, then they will sound an alarm, and she can immediately skip the work, or she can adjust her position to reduce it. So in here now, what we say, now we will see that we are having radiation in many areas, from space, from industry, from nuclear power, natural radiation, with different sources. But you see here the medical application, what we told in the 3 area is the large population are having this radiation. And for this, there are some international policy relationship for radiological protection have been developed. Like BSS, what we everyone know, the basic scientific studies from, and then since this scientific study has been evaluated by the UNSIR, and then International College of Radiation Protection comments some recommends for the industry, from the professionals, and then the IEA BSS international safety standards is produced, and from all of them, every country has made their own national regulations. So when we talk about radiation principle or radiation safety, 3 things we must keep in mind. One is ALARA, that means as low as reasonably achievable. So patient must be informed. When it is patient, we must inform them the risk and benefits. And when we are the healthcare workers, we must know the appropriate radiation protection to minimize the exposure. And the second thing is very important, why we are giving this radiation. The justification is very much important in diagnostic, in therapy, or nuclear medicine. We have to justify that benefits and potential risks. Alternative procedure we should also know, so that if it is needed, we can consider. Optimization, the third one, that involves the minimum radiation exposure by the appropriate imaging technique. That means equipment should be calibrated, and on the other hand, image quality should be optimized for repeat procedures and additional radiation exposure. And lastly, the dose limit is very important. It must be within safe level. And it is we know that it's depend between among the procedures and patient age and condition. But however, we must think healthcare workers must monitor the radiation exposure levels and ensure the safe limits. So here the things we are using, this lead aprons, gloves, goggles, and these things, and this radiation protection framework that we know, ICRP, UNSIR, and IEA, and then member states doing this thing. These are the all protocols we have seen that you will available in the website everywhere. So whenever we do which area we are working, so we can download it and we can study before starting the radiation safety. So for this reason, I know in Bangladesh and everywhere, this is we call the RCO, Radiation Control Officer. As a medical physicist, they must give another examination to be recognized as a RCO, because they should know the all hospital radiation instruments related radiation protection. So IEA has different kinds of things. You see the safety series. This is a safety fundamentals first, safety requirements, and safety guidelines. So fundamentals is about the radiation source we have seen, and the safety requirements, what are the needed, and safety guidelines for everyone, EBRT, brachytherapy, diagnostic, everywhere there are the protocols. So these are the dose limits, what we tell in the NCRP and ICRP. So occupational exposure, everyone those know, because there are 2 protocols we usually use, NCRP and ICRP. There is some difference, but the meaning when we convert it is the same. Occupational exposure, cumulative and annual. We do 10 millisievert according to age, and 20 millisievert for over 5 years average. It is the ICRP. And annually, when the 50 millisievert per year as per NCRP, and ICRP 50 millisievert per year is the same. And for lens, for skin, for embryo, for fetus, everywhere the dose is different. So we have to be very careful, and we have to type it, and we have to, maybe we cannot remember, but we have to be very careful. We can paste these papers in front of us so that we can see whenever we do any kind of treatment to the people or embryo or pregnant women. So we have to know these things. And effective dose, you know, that's with the after pregnancy, it is the 0.5 millisievert or total 1 millisievert to the abdominal surface. So radiation therapy, these three things were, so radiation protection, we have to do in 3 areas together. If it is in teletherapy, if it is, we are giving to the mother, so there are some protocols. I'm not going to line by line. I think it will be distributed. So here you see that how the fetus positioned, the mother, how the position, how the peripheral dose, how it is taken care, the internal scatter, leakage and scatter of the treatment unit. So early pregnancy, what will be the treatment from the source to the distance to the treatment site, it is approximately 40 centimeter. Late pregnancy, it is a 10 centimeter. So we have to know this, and we have to make this position when we'll do the treatment or diagnosis. Same as brachytherapy, when we have to do temporary implants. So that means dose rate never exceed several milligram per hour, depending on the implant site and radionuclide. When it is a permanent implant, so we have to, you know, the patient will be released after several days. So radiation safety instruction given to minimum dose to infant during breastfeeding. And for low energy, it is attenuated easily. So we have to not think about these things. There are many publications for the pregnancy and neonatal outcome has been, you will see in that there are many publications now have published. So this is the diagnostic. I think this is the extra-abdominal, analytical, and external radiation sources. We have to think about the developing embryo and fetus. Also, the extra-abdominal exam, when we do, it must be less than 0.1 millisievert. Analytical experiment should not receive any measurable dose during operation. And we have to think also, external radiation dose normally do not affect on the milk production or breastfeeding. So there are all the things, you know, who are the in radiology. You see here the total maximum dose is given. You see intravenous urogram or lumbar spine pelvis. Also here on the right side, you see barium enema, maximum 24 milligrams given. So for this examination, we have to also taken care of the patient. For the fluoroscopy, when there is a fluoroscopy, head unit is the below the extra tube is the below, then it is less, but it's when it is above the table, then it is more. Cardiac catheterization, when in pregnancy, we must know about the lead apron must be wrapped around the mother's abdomen, and at 4th month, normally volume of fetus is very small, so there must be a great distance between the fetus and chest. Normally, the range of the dose is 2 millisievert. This is the nuclear medicine. What I think one of the experts, NURSAKINAH, will tell about this. So what about the thyroid dose, full body dose in case of women? From pregnant and breastfeeding, you know, these radionuclide which are using that must be excreted in the breast milk. So we have to know that breastfeeding that time is suspended, and it is completely after the therapy of iodine 131, and 3 weeks after these things, and 4 weeks after technetium, DTP, and phosphate. So it depends on the which kind of radionuclide we are using, and short-lived radionuclide usually do not cause any large fetal dose, but fetal dose can be reduced by the maternal hydration and encouraging voiding of the urine. So young workers, we have to very much concentrate, because under 16, we should not be anyone to do any occupational exposure. Even the 18 years age under, so they can work in the controlled areas only for training purposes with close supervision. But in here, Schedule 2, the BSS normally prescribe 6 millisievert in a year for person under the 18 years old. And reproductive age, last menstrual period must be confirmed, and cancer induction is probability when there is in reproductive age in diagnostic intervention. So employer, what will the responsibility the employer? So we have to tell our employer that when we are pregnant, and to know the administrative superior, that means it may be director or the radiation protection safety head. So one, it is declared the fetus treated like it as a member of general populations. So careful evaluation of the women's environment and risk assessment as well as full potential risk has to be explained to the occupational worker as well as the patient. If we cannot exclude the pregnancy, in that case, depending the type of the medical exposure, special attention we have to give in, and we must do whatever we think must be justified. So another thing we cannot, we usually discourage the research on pregnant patient, and proper shielding dose monitoring is important. Alternative imaging modalities we have to consider. And radiologists must understand why we are doing this concern and why we are doing this diagnostic level. So what we have said, we have stochastic effect. When we do not allow these things, there will be leukemia, cancer, and this the heritable effects, the genetic effect is done. The another, when at the time 1978, that Pregnancy Discrimination Act was passed, that women will not work in the radiation facilities when they are pregnant. But IEA has discouraged this discrimination toward pregnant medical radiation personnel. Instead, the agency encouraged hospitals to allow an expectant woman to continue working in her regular setting, provided the fetus is not exposed to more than 1 millisievert during gestation. So in that case, expectant women should only continue to work in radiation setting of her own violation, not because an employer mandates it. So these are the ICRP and NCRP recommendations. So you have known that we usually follow the ICRP, that less than 1 millisievert for the total fetal exposure during entire pregnancy. And ICRP, a limit of 2 millisievert, only the surface of the abdomen, lower trunk for the remainder of the pregnancy. And when after declaration if the pregnancy is done, that the fetal dose should not be exceeded about 1 millisievert. So there is some difference, but according to the people and the specificity we follow, but those are okay, and NCRP, ICRP we can follow. These are the references, and thank you.
Thank you very much, madam, for your insightful presentation. This is really important for the women who work in the radiation environment. And this insightful information provide us the guidance how we should work and what are the procedures we should follow. So far in the chat box, we got only one question. So if a pregnant woman is accidentally exposed to radiation without wearing a dosimeter, is there any test or method available to estimate the radiation dose received by the fetus? This is the question to you. So is there any method to get the estimation of the fetal dose?
Then you have to wear what I say active monitor. There are some dose monitoring there. So you have to measure, though you have forget or you don't know that you are pregnant, but you wearing you do not wear the dosimeter. But after that you can monitor your fetal dose. There are other dosimeters that you can monitor your fetal dose. So just see these things, and also you do the ultrasonography and some, if you think that it will be the long-term effects, there are some karyotypes or karyograph, the gene test you can do. But if you are more conscious about this, but you have to also just like TLD, we can measure how much dose is needed. So you can measure your dose in the abdomen to the fetal dose.
Okay, thank you very much. Is there any other questions from the participants or from the organizers? So there is another question. Can MRI be dangerous for pregnant women?
No, this is not ionizing. So no, but we always tell without any no, very fruitful causes, if it is very mandatory, otherwise not go to any intervention process. If ultrasonography is okay because we have to see the side, but MRI also sometimes electromagnetic wave, but it's though non-ionizing, we should not use very much more.
Thank you. So far, there is no questions. Is there any other questions from the participants? So still we have, few minutes. If you have any questions, you just let us know.
Okay, thank you.
Okay,
I have to
thank
leave.
you.
If any question, please send them to my email ID, so they will. I will answer the questions.
Okay, madam. Thank you. Thank you once again for your presence today. So now we will move to our next speaker. So our next speaker is Associate Professor Dr. NURSAKINah BINTI SUARDI, and she's from University of Malaysia. She got her PhD in 2015 from the University of Malaysia, and before that he did her master and bachelor from the same university. She has received more than 6 research grants as a principal investigator, and she has mentored about 50 PhD and graduate students. She has published more than 50 publications in the national and international journals. Dr. NURSAKINAH has many associations and the affiliations in the different organizations and societies. She is the current secretary of Malaysian Association of Medical Physics, and she is the current member of the Award and Honors Committee of AFOM. She is the member of the Malaysian Allied Health Professionals Council, and she is lecturing as an adjunct at the BINTI State University. He is the member of the Medical Physics Program Standard Development under Ministry of Health in Malaysia. She is also the member of the Global Research Education Subcommittee at AAPM, the member of the Malaysian Society of Neurocognitive Clinical and Behavioral Imaging, lifetime member of the Malaysian Institute of Physics, lifetime member of the Malaysian Association of Medical Physics, and she is also the member of Organization for Women in Science for Developing World OWSD. So now I would like to invite Dr. NURSAKINAH BINTI SUARDI to deliver her speech.
Thank you so much, Dr. Akhtar. So let me share my slides. So my topic today will be, just now, Prof. Hasin and Anupam was actually focusing more on the ionizing radiations. So my topic will be more towards the non-ionizing radiation, focusing on the 3 instrumentation, which is the MRI, ultrasound, and laser applications. So non-ionizing radiation basically refers to the electromagnetic radiation that do not carry enough energy per quantum to ionize the atoms or the molecules. So basically it cannot remove a tightly bound electron. So there is no ionization actually occurs. So unlike ionizing radiation, you can classify them into a lower energy forms of radiation like ultraviolet, visible light, infrared. We have radio frequencies and microwave, low frequency fields, static fields like a magnet, and also ultrasound. But ultrasound is not part of the electromagnetic, it's actually a mechanical waves. So non-ionizing radiation include technologies that commonly use, which is what I'm going to talk today, which is MRI, ultrasound, and lasers. So while generally safer in terms of the radiation exposure, but then we cannot say is that they are not without risk. And especially with the advance of the technology now, we have an increasingly sophisticated devices that exploit non-ionizing radiation, and it's actually been introduced into the clinical practices. So it's important for us to ensure that their usage does not carry any unwarranted risk to the health. Basically, in terms of the principles of the non-ionizing radiation protection, so it's adapted similarly with the one that we use in ionizing radiation, based on the three key principles, which is justification, optimization, and also the limitation. So in terms of the justification, non-ionizing radiation exposure also should not occur only if it provides more benefits than the harms. We also need to keep the exposure as low as reasonable achievable, which is based on the ALARA principles. And then in terms of the limitation, we should not exceed the recommended exposures levels to avoid the known adverse health effects. But these principles has been adapted to fit the characteristics of the non-ionizing radiation. Especially now, basically, we do not have that much of the deterministic effects coming from the non-ionizing radiation. It's mainly on the stochastics. And then we do have some of the exposure threshold that is, for example, the one that are able to cause the tissue heating and also the nerve stimulation. There are several categories in terms of the exposure. We have the occupational exposure, which is applied for those workers in the controlled setting, which was assume that they are actually in the good health, exposed up to 40 hours a week if you consider them working 5 days a week. And then these workers are actually informed about the risk and also the protective measures. And we have the general public exposure, which is include the children, elderly, and the people with the health conditions. For this general public exposure, basically you need to have a stricter limit due to the greater sensitivity and also their lack of awareness. They may not be understand properly what is the effects coming from them exposed to the non-ionizing radiation. And then we have the medical exposure to the patients, those who involve for the diagnostic and the therapeutic purposes. It could exceed public limit if you justify them by the medical benefits. And then we have a special consideration just now, like Professor is talking about the pregnant workers, volunteers, the carers that may have to accompany the patients into the imaging. And also we have the emergency responders. So let's first talk about the first instrument, which is the ultrasound. So ultrasound is a form of energy. It's mechanical, it's not electromagnetic, and it propagates as a high frequency sound wave more than 20 kilohertz. So it's operate typically at 1 to 240 megahertz. It's widely used for the imaging internal anatomy. Actually, mostly used for the fetal development during the pregnancy, but we also do it for the other non-obstetric reasons. So despite its routine use, many ultrasound operators, especially if you know about ultrasound, is actually a very operator dependent, including the sonographers and clinicians that have the lack of detailed understanding, especially in terms of the acoustic outputs. Most will actually rely on the preset by the manufacturers itself without knowing that we actually have the TI, which is the thermal index, and the MI is the mechanical index values. And it's also possess some bio effects, which is the tissue heating and cavitation, especially in the fetal tissues. And the safety practices, which is we misuse of the Doppler in the early pregnancy, while the fetus actually are very sensitive towards any sort of radiation. And we also could have involved in the prolonging scanning on the sensitive areas. So this is an example of the clinical applications that we currently use in the ultrasound. So you can see that different types of the imaging that we use will have a different frequency range that is involved. So, and then with their own respective functions. So in terms of the epidemiological studies, basically we says that there is no harmful effects in the human fetuses, but mostly of the information obtained with the pre-1991 machines. So FDA at the time also has allowed the acoustic output of the US ultrasound machines for the fetal use to be increased from 94 to 720 milliwatt per cm square, which is a factor that's almost 8. So you can see that there is a huge jump from the 94 until 270. But then the main reason why this huge jump is because of more sophisticated machines actually related to ultrasound has been developed. And especially that now we have involved the Doppler imaging, which requires more frequencies, and then that's somehow like contributed to the increment. But then FDA says that even though the limit is 720, but it's still up to the user to operate them safely. So it's important for you to know what is the safe limit of the usage. And the manufacturer actually have aided on the screen safety indices. I'm not sure if you are aware of it or not, but we have something that we call the TI in the ultrasound machine and the MI, which is the mechanical index and the thermal index, that you can actually observe what is the values and get to know what is basically the limit, the safe limit, and the guidelines of using. So some of the biosafety concerns of the ultrasound is the thermal effects, which is involved in terms of the heating, which is the absorption of the ultrasound of energy in the tissues. It's also, there is a risk increases with the high intensity, long exposure time, and if it's actually interact with the bone in the air interfaces, for example, the fetal skull and also the lungs. And these thermal effects actually quantified by the thermal index, which is a measure of the temperature rise potential. And the second effect you have is a mechanical effects, which involve the cavitation. So it's occur from the oscillating gas bubbles in tissue under the ultrasonic pressure. So this risk of the cavitation, basically you monitor them through the mechanical index. So higher MI values may increase likelihood, particularly with the contrast agent or in the fluid filled areas if, for example, you try to image in terms of the lungs area. This is the obstetric scanning that we can see that for the thermal index. So if it's actually increased in terms of thermal index, so you will see that there is we encourage you to have less and less exposure. And if it's actually above 3.0, it's not basically recommended in the OB scanning. So you can actually check the setting in the ultrasound. And this is also another table recommended. So you can see there is a TIS. This one is actually, we have a different thermal index for the soft tissues, for the bone, and for the cranial, because different structures or different anatomies would actually have different effects in terms of the thermal. So we have like, if it's below 0.7, so we could consider that there is no limit in terms of how long you do the imaging. But then if it's within 3.0 to 3, this one is for the obstetric. So we have like a suggestion, what is the restriction of the time, so that you won't have the effects coming from the thermal towards the fetus. And then this is also the mechanical values. So if it's above 0.7, then you could have a risk of the cavitation, especially if you're using it with the contrast agent. While the fetus is more sensitive, but then if it's for the non-obstetric or non-neonatal ultrasound, you can see that the values for the TIs is a bit more increased. So if it's more than 1.0, then only you started to will somehow like restrict the time. And also in terms of the risk of cavitation also increase compared to when you do the imaging on the fetus. So according to the ICNIRP, so the balance evidence now available does not point to any harmful effects either in the patients or the healthcare workers from the exposure to diagnostic ultrasound as used in the normal clinical practices in the absence of the contrast agent, because contrast agent is actually quite new to be used in the ultrasound. However, there are a few reports, there are some of the risks about the congenital malformations following the exposure of ultrasound in the utero, particularly in the first trimester. However, we still need to do a further research related to this, and that could have a potential for the adverse effects from interaction between ultrasound and the contrast media. So this one is just a key principle for the safe use of the ultrasound. So you should only use this ultrasound imaging only for the medical diagnosis. Ultrasound equipment also should only be used for the people who are fully trained in its safe and the proper operation, which requires an appreciation of the potential thermal and mechanical effects of ultrasound. You should also be full aware of the equipment settings, because ultrasound is really operator dependent. And then understanding of the effects of machine settings on the power levels. And examination time should also be kept as short as is necessary to produce a useful diagnostic results. And the output levels also should be kept as low as reasonable achievable while producing a useful diagnostic results. And the operator should aim to stay within the BMUS recommended scan times, especially for the obstetric examination. And this is also something that I would like to remind, that scans in pregnancy should not be carried out for the sole purpose of the producing souvenirs, videos, or photographs, because this is very popular. I'm not sure about other country, but at least in Malaysia, it's so popular that you are kind of, the mothers or the father are kind of eager to see their unborn baby. So this is several other professional bodies issue that you can actually refer to in for the best practice guidelines and their safety protocol, because we have like a lot of organizations that you can refer to. I could not actually able to go deeper for each of the equipment because of the limited of the time. Now let's move to the MRI, it's widely employed method clinical investigation, which, as you know, that it's used a static magnetic field. So generally in the range of the 0.5 to 7 Tesla, in combination with the time-varying non-period EMF, which is the gradient, and then you have the radio frequency EMF, which is in the range of the 20 to 300 megahertz. And the usage of MRIs is basically increasing globally with the medical devices continually being developed and also upgraded. So it's actually in rise in terms of the usage. In the 2027 itself, the procedures of for MRI globally is actually more than 100 million per year. And it's also rapidly evolving. We now have medical devices and also implants that is suitable for the MRI, actively shielded magnets, more powerful and faster slewing gradients, increased field strength. And MRI also are no longer located just in the imaging centers, because MRI now also used for the intraoperative or interventional radiology. We use it also in the research and animal imaging centers, and also in the radiation oncology, because now we started to have the MRI LINAC instead of just the normal CT LINAC. So now we have also MRI LINAC coming into the pictures. So if you look into the overall view of the MRI, there are actually a lot of other things that you wanted to consider, but for today's talk, I will just consider three main things. The first one is the static magnetic field. So we know that the MRIs actually have a very strong magnetic. It depends on, it's either normally in the diagnostic, we go from 1 to 0.5 to 3 Tesla. So even if 1 Tesla itself is already 10,000 Gauss, which is our Earth magnetic field, is just 0.5, which is 20,000 times stronger than the Earth. So now you can see that we are actually really using a very strong magnet. And then it's always turning on. So this is also one of something that we wanted to figure out, what is the safety effects that are coming from the static magnetic field. The second one we have is actually a gradient magnetic field. So this one is important for us to do the spatial encoding in order for us to localize where is the signal of the MRI coming from. But there also have some safety consideration involved with the gradient magnetic field. And the final one we have is the radio frequency. So radio frequency is transmitted through the coils, which is a wave that at the end is also important in order for you to also get the image from the radio frequency. But again, there's also some of the effects coming from this. So in terms of the interactions, so I mentioned to you just now, we have the static magnetic field, also the spatial gradient. So it's attractive and talking forks. So one of the effects that we can get is actually the projectile effect and also the device displacement. So if you're actually wearing any implant, so because if it's somehow like attracted to the magnet, so it may cause a device displacement. And then the time varying magnetic phase gradient, which is induced currents in the metal surface, current loop. So it may cause the device malfunction, tissue stimulation, and also the device heating. And we also have the pulse radio frequency energy, which is the intense electromagnetic fields, antenna effect, which may cause in terms of the thermal injury, device malfunction, and also the tissue stimulation. So according to the IEC, we recognize MRI in the 3-mode scanner operation. So we have the normal, which is requires only routine monitoring of the patients. We also have the first level control, which is required medical supervision and the medical assessment of the risk versus benefit for the patient having the scan. And the second level control, which is required approved human study protocols, security measures, it may, like, for example, password are provided to prevent the unauthorized operation in this mode. So if we see the most of the layout that we have in the MRI units, so MRI normally, like, we define a certain area which contain the MR environment, and the access shall be restricted and suitable warning signs should be displayed at all the entrances. So you can see that it could have 4 zones in the MRI units. The first one is the zone number 1, which is the waiting area. It's basically just the outside of the MRI environment, which you could also consider as a clean area. And then you have the zone 2, where the patients will change into the MRI safe gowns and are screened for the MRI safety issues. Because it's also important that you have to make sure that the patient does not carry any metals in their body. So this is where you screen them. And then at the zone 3, which is considered of the control zone, which is highly restricted and also only meant for the authorized personnel. And then the last one where the scanner is, which is where the highest risk available. So in terms of the safety considerations, so if you take a look at about the static magnetic field, it may have several primary concerns, which is the most common one is a projectile missile hazards, which is some of the metals may be attracted to the ball, and then we have the medical device displacement, medical device disruption, and also the bio effects. And then we have the radiofrequency field, which is may cause the tissue heating, medical device disruption, interference with the auxiliary equipment for the patient monitoring. Because some of the patient, when they go through the MRI, they also need to be monitored by the EEG or any other equipment together while they are doing the imaging. And we have the pulse gradient magnetic field, which is could have involved in terms of the peripheral nerve stimulation, the acoustic noise, and also the interference with the auxiliary equipment. So for the static magnetic field, you know that the strongest hazard coming from this is actually the projectile effect. So the ferromagnetic objects within the magnet image can be forcefully pulled towards the ball. So it will possess serious risk to the both people and also the equipment itself. So since we have the static magnetic field always on, so the projectile hazard is basically considered constant, and all the potential metallic projectiles must be kept outside the MRI environment. So in terms of the radio frequency, as you know, the radio frequency is actually EMF. So it contains both the electric and magnetic field. So at the megahertz range, most of the radio frequency power will somehow convert this heat in the body. So at the rate, how do we measure the radio frequency energy deposited into the body is actually expressed in the SAR. I did some of the interaction between me and the radiographers and some of the medical physicists. So some of them don't even know that MRIs actually have something that we call SLR in their units. So this is something that I think we should be more aware of because we should actually do this monitoring during the imaging so that we can prevent the RF energy exceeding the recommended levels. And metal objects within the radio frequency field also can absorb energy and become hot enough to cause the burns if in direct skin contact. And current-induced burns can also occur at small skin-to-skin contact point. So in the image over here, I show that those actually having tattoos and then underwent the MRI, so it may cause like a first-degree tattoo burn because the contents of the tattoo is actually also some of the metallic materials. And then we have the image over here is the third-degree burn from a pulse oximeter cable. So the toe at the end required the amputation. And the specific absorption rate basically measured in watt per kilogram. It depends on the patient weight, the flip angle that you use, lumbar frequency, the strength of the magnetic field, the duty cycle, and also you can see that the SAR hotspot can occur near the implant. So if there's like some implant materials, even though in the non-ferromagnetic wires, so it may somehow cause a heating, more heating hotspot in that area, which you should be aware of. And then we have the third one, which is a gradient magnetic fields. So gradient magnetic fields basically rapidly switch on and off during the procedures to enable the spatial encoding in MRI. So that's how we create the gradient magnetic fields. So when you do the turning on and off, they basically induce an electrical currents in the body. So this follows the Faraday's law. So the magnitude of the induced current depends on the factors such as the maximum strength and the rate of the switching. So if it's actually strong enough, it somehow will generate the currents. It's because it's induce a current and it may stimulate the peripheral nerves, muscle fibers, or in theory, even the cardiac tissues. So this is something that we also need to be aware of. That's why sometimes a patient may complain that they feel hot when they are actually inside the MRI units. So I, based on the IEC 60601, so I did list a few parameters. There's actually a lot more other parameters, but this is some of the parameters that I listed out. For example, like for the static magnetic field, we in the diagnostic, basically we are operating under the normal mode. So first level control and the second level is actually for the special cases and also mainly used in the research. So it's not basically in the diagnostic. So I would say that we are still okay in terms of the SAR part and also about the body temperatures or temperature limits and also the percentage of the peripheral nerve stimulation. but it's good to actually be aware of what is going on inside the patient when we do their imaging. So let's move into the last instrumentation, which is the laser. Laser is a light amplification by stimulated emission of radiation. It's basically a device that generates intense beam of coherent, monochromatic, and collimated light. And how do we process how we produce with laser is by the stimulated emission of the photons from the excited atoms or the molecule. Lasers actually have a quite range of wavelengths. We have different types of laser and for different types of applications. So for medical laser, it's ranging from 300 nanometer up to 20,000, like 10,600, which is the carbon dioxide lasers. We use normally for ultraviolet is mainly used for the LASIK surgery and then other types. The commonly used in the surgical is actually carbon dioxide. We use it for the cutting during the surgery. So each of the laser when it's actually produced, it depends with the gain medium. If you are not aware how the components inside the laser, different wavelengths actually produce with different medium. So we have it's produced, for example, carbon dioxide laser, the gain medium inside is actually a gas coming from the carbon dioxide. We have helium neon. We also have a solid state laser, for example, the Nd:YAG or ruby lasers, and we also have a dye lasers. So each of these, actually, even if the gas is a compressed gas, there's also a safety precaution that may come with the usage of the laser. So how do we classify the laser based on the classes, based on the hazards? There are different ways, but in terms of the safety, we go with the hazard, how much that the laser can cause the hazards. So if it's actually class 1, so basically this one is low power, safe to view. And we have class 1M, it's low power, but then if you view it longer than 1,000 seconds, then it could actually possess some hazards. Class 2 is still low power, but you can see that you can only view it like more shorter before it can actually cause any hazard. And then class 2M is also medium power. It's non-hazardous if you view it less than 0.25. You have a 3A, which is medium power, 0.5 watt. It's hazardous when viewed directly, regardless it's how many seconds. Same goes to 3B. And the higher power laser is actually class 4. So you could consider them 3B and below is a low power laser, and the class 4 is actually the high power laser, which you also classify them according to the output power that they produced. And in terms of requirement, whether it needs training or whether it needs a medical surveillance or whether you need laser safety officer in order for you to conduct the usage or to use the laser. This also depends on which classes of laser that you are actually used. But of course, it's actually coming from the 3B and above and 4, you're actually needs to have a laser safety officer because of the hazards that you may possess. So in terms of the laser therapy, you may have like 2 types of how the laser is used. It's either using a photothermal, which is you need to produce a heat coming from the laser, which is commonly go by the high power laser, and the lower power laser may use for the biostimulation in terms of the therapeutic effects. And I just put in some of the images on how where normally laser is used in terms of the application. The commonly that we use is actually laser for the alignment, meaning like you wanted to align the patient, position the patient, then we have a laser coming over here. I did a measurement, what is the power of output power of the what we call it, the alignment laser over here. It's low. However, you have to remember that our eyes have a lens which may able to, we call it, increase the impact of the laser when it goes into the eyes directly, because sometimes it's worrying seeing that radiation therapies or radiographers when they are about to position their patients, but then just allow the laser to simply go through their eyes. So we may want to be more careful in terms of this. And laser can also go for LASIKs. The most commonly go for aesthetics, hair removals, for the skin regeneration, removing the scars, and also used for the rehabilitation, those inflammation. And this one is actually a blood therapy and acupuncture. And some of the laser parameters that involved is the wavelength, power density, duration, laser beam size, whether the laser is actually pulse or continuous. So each of these actually will determine the hazards of the lasers. And then in terms of the tissue absorption, it also depends whether what are the absorption of the tissues, thermal conductivity, the local circulation, whether it's available, whether the blood is actually available nearby the procedures of the tissues, or there is a scatter. When we classify the laser, we have two types of hazard. The first one is the hazard coming from the laser beam itself, and then the non-beam hazards. So if the beam hazards, we have identified like two biological effects and damage, which involve the eye and also the skin. It may also cause a fire and explosion. The plum, which is laser-generated airborne contaminants, because sometimes when you do the procedures in removal, for example, tumors, because of the high power that we use, it may produce a smoke coming. And then that smoke, if you're actually removing something that may have like pathogens or something, so it may it's somehow like, and then you inhale them, it's maybe end up into your body. It may end up into your lung. So this is also something that you have to remember, that if the smoke coming from the laser, then try to avoid inhaling them. And then we have a non-beam hazard, which is electrical hazards, compressed gases, like I mentioned just now. You could have like carbon dioxide, the medium is actually a gas inside. And then could have the toxic fumes, and also the dyes and the noise. So some of the laser also actually producing a very loud noise. So you also may want to consider an acoustic effects coming from the lasers. So in terms of the eye exposure, there are actually a few ways how you may be exposed to the laser effects to your eyes. The first one is the intra-beam exposure. So this one is basically just directly. So if you have a laser, then it's directly pointed into your eye. We do have a specular reflection, which is a reflection from a mirror-like surface. It could be a mirror itself or something that is like a mirror. And then for this case, even though it's reflected, but you may consider that it's retained its original power. So it may go full force like a direct exposure. And then you have another one, diffuse reflection. This one is reflection from the dial surface. Some of the people may, like when they adjusting the laser or doing some of the what we call it, checking of the laser, they may wear like something what we call it watch or jewelry or just rings. All those things, rough surface actually can somehow like are able to scatter the laser light. So that's why something that we want to make sure of when you handle the laser, it's good to remove your jewelries and also the watch. In terms of the laser eye hazards, we have the thermal damage and also the photochemical damage. So thermal damage basically in the retina occurs in the retinal hazard region, from the 400 nanometer to 1400, which is from the blue region or violet region to the infrared. So thermal damage, if it's actually not cumulative, meaning like it's just like one off, then we could say that you can still consider that your retina are able to cool down between the exposure, but then it will be damaging if you are continuously being exposed. And then for the photochemical damage is severe at the shorter visible wavelength, which is sorry, 100 to 400 nanometer. And it's also cumulative over a working days. And the eye can focus a cumulative beam. This is also something that I want to emphasize on. You know that in our eyes, we have something that called lens. So laser is already a collimated beam, and then it produces a very intense beam. So when it gets into your lens have a focusing effects. So it will focus and then falls directly into your retina where the image is actually produced. And the impact to your retina may go with 100,000 times the radiant power that has entered the light. So you can see how the impactful to your eyes. So it may actually at the end cause a blindness. And we also have an inflammation injury to the cornea, which is caused by the UV range wavelengths. This is a same type of the injury caused by the snow blindness, and may also can cause a cataract if you are dealing with the ultraviolet wavelengths. Because one of the UV effects, basically you can, because part of the UV is considered ionizing radiation and still can cause a skin cancer. And this also, if you are dealing with the UV laser, you also need to be careful because it may cause you having a cataract. And then in terms of the skin hazards, if it's using ultraviolet, like I mentioned just now, this injury is actually comparable to the sunburn, and the damage can also give you an increase in terms of developing the skin cancer from the UV laser exposures. And we have also a thermal injuries, especially if you are using the high power class 4 lasers, especially from the infrared and visible range of the spectrum. So it can actually burn your skin and even burn the set of the closest to the fire. So this one is just an images I found. This lady actually went for a dermatology to somehow do a skin regeneration, but ended up getting burned by the lasers. And this lady is actually doing what we call it hair removal procedures, but then it's also ended up burning the lasers. So when the next time that you wanted to go for this kind of procedure, so you may want to think further. And the common unsafe practices that we can find in handling the laser is you may not wearing protective eyewear during the alignment procedures, not wearing protective eyewear in the laser control area, misaligned optics and upwardly directed beams, lack of protection from the non-beam hazards, failure to follow the laser safety instructions, bypassing of interlocks, door and laser housing, insertion of the reflective materials into the beam path, turning on the power supply accidentally, and wearing the wrong eyewear. If you have ever worked with the laser before, you may know that we need a goggle to actually, or the eyewear to protect our eyes with the laser. But then most people who doesn't know is you cannot just simply wear any eyewear. So each eyewear that we have actually have sort of a filter that will filter several wavelengths. So normally in the eyewear they mention to you like this eye protection can protect you from which wavelength. So you need to know like what wavelength of your laser is actually using, and then check whether the eyewear that you are actually wearing are able to filter out those wavelengths or not. So not just simply use any available eyewear. So how to prevent these accidents? So no unauthorized personnel will be in the room or the area. Laser protective eyewear should be worn. The individuals who moves or places an optical components on an optical table is responsible for identifying and terminating each and every stray beam coming from that component. And to reduce the accidental reflections, like I mentioned previously, the watches and reflective jewelry must be taken off before you do any alignment activities. And the beam blocks must be used and also must be secured. And when the beam is directed out of the horizontal plane, it must be clearly marked, and the lowest possible power must be used during the alignments. So that's all from me. If you have any other question, you can actually send also to my email. Thank you.
Thank you very much, Dr. NURSAKINAH. This is sometimes actually when we work at the radiation area, we always think about the ionizing radiation, but there are definitely adverse effects of non-ionizing radiation also, and your presentation is really important for us. So far we
Yes.
got one questions. Non-ionizing radiation have any radiation safety protocols?
Yes, they are actually. They have a lot of guidelines coming from the NCIRP, which is we have those actually working with the ionizing radiation. We also have a non-ionizing radiation bodies, but they may have like sort of like a guidelines. It may not as much as protected as much as the ionizing radiation, but for the non-ionizing radiation, we still have a guidelines and also radiation safety protocols for us to follows actually as a guidelines.
Yeah, this is really required. Myself, I recently just established the standard operating procedure for the laser in my hospital. Anyway, there is another comments. The another most important issue is the lacking of enough knowledge of operators in working with lasers. I think this is really true.
Yes,
And
I
if you have
agree actually.
any comments on that, just please let us know.
Yeah, I actually believe the same thing. Most people will actually have this kind of problem. Even in Malaysia, we do have a guidelines about laser, but then still it's not as regulated as how ionizing radiation is regulated. And I do have like some people that reaching out to me asking what they should consider when they end up have to taking care of the laser, because nowadays like some of the hospital will put the task of monitoring the laser to the medical physicists if they do not have their own laser safety officers. or the medical physicist itself may end up becoming a laser safety officers.
Yes, yes, exactly. Yeah. So we got another question. In ultraviolet radiation, are there any exposure limit for definitive skin cancer effects?
I'm not aware of this at the moment. We know that there is actually because in terms of the cancer, you could consider it as a stochastic. So we do not actually have sort of like a possible limit because it's a cancer. Any other sort of radiation that we are actually using, basically it falls under the stochastic, like a chance whether you have it or you're not. So same goes to ultraviolet radiation. So at the moment, I do not know any exposure limits that may have imposed in terms of the UV radiation. But we do have, like, same goes to how we go with the ionizing radiation, where you have you should justify the usage. You should also try your best to use a lower power and then low exposure, something like that.
So the question from the same participants, has any research been done in this area?
For now, I'm also not really aware of that, but it's not because we did not consider them deterministic. We still consider them as because cancer is actually part of stochastic effects. So in terms of the limit, at the moment, we're still not sure how much that she may contribute. But then again, we should just follow the regulations, try to go with the LRF principles in terms of that.
Thank you. So far there is no questions.
Welcome.
Yeah. So now we would like to move our next speaker and the last speaker. So our last speaker of today's AFOMP school is Muhammad Amin MOSLEH-SHIRAZI, PhD, and he's from Shiraz University, Iran. He's the member of the AFOMP Awards and Honors Committee, and he was the past president of the Iranian Association of Medical Physicists. He is the head of the Radiotherapy Physics Unit, Associate Professor, Department of Radio-Oncology, Medical Physics and Radiology Technology. And he is the former head and founding member of Ionizing and Non-Ionizing Radiation Protection Research Center. He is the founding member of Medical Imaging Research Center, member of National Examination Board of Medical Physics, National Examination Board of Radio-Oncology, and also the member of National Radiotherapy Steering Committee. He received his bachelor, master, and PhD in medical physics from UK, and he is the IPM higher training in radiotherapy physics in UK. So he is the registered clinical scientist, health and care professional councils, chartered scientist, science councils in UK, and he has extensive professional experience in radiotherapy in the more than 30 years. At the Royal Marsden Hospital, it's about 9 years. Sussex Oncology Center, Namazi Teaching Hospital, Iran. This is also about 20 years. He has about 140 papers, 200 conference abstracts, and more than 2,000 citations. He is the member of editorial board of 4 scientific journals and was the past guest associate editor of medical physics by AFM. So now I would like to request Professor Muhammad Amin MOSLEH-SHIRAZI to deliver his speech.
Hello, everybody. Can you hear me?
Yes, we can hear you, Professor.
Excellent. Thank you so much, Dr. Akhtaruzzaman. I would like to thank the AFOMP for inviting me to this presentation in this AFOMP school, in particular Professor Hasin Anupam and Professor Jinjian for this. I hope the presentation that I will give is as good as the previous 2 excellent presentations and would follow the theme of radiation protection. I would like to share. Okay, I'm hoping that that you have my slides and that I can now go ahead. The title of my presentation is Specific Safety Guide 46 on Medical Uses of Ionizing Radiation Implementation in Radiotherapy. I would like to switch off my video for the moment, I think, just to increase the bandwidth. And I'm going to focus on implementation in radiotherapy. I have no conflict of interest to disclose, and I would like to acknowledge that the slides were selected from IAEA teaching material with permission, of course. Okay, as an introduction, I would like to point out the system of IAEA safety standards or hierarchy. At the top of the tree, you have the fundamental safety objectives and principles of protecting people and environment, i.e. the moral obligation level, such as we do not want to harm patients, for example. Below that, we have these safety requirements in the language. You use shall because there's legal obligations in here, and these are requirements that must be met. And then below that, there are applicable procedures, recommended ways of meeting these requirements. The language uses the word should, and these are these specific safety guides. And I want to concentrate on one of these, which is Specific Safety Guide 46. This is the latest the IAEA has on radiation protection and safety in medical uses of ionizing radiation. This is a joint effort by several big organizations globally, and supported and contributed by organizations, societies such as the IOMP, such as the ESTRO. SSG 46 is aimed primarily at end users in medical radiation facilities, managers, medical practitioners, medical physicists, radiation technologists, etc. And it provides recommendations and guidance on regulatory activities and infrastructure. So it talks to regulatory bodies, health authorities, government agencies, and also professional bodies such as medical physics societies, etc. This document, the SSG 46, is subdivided like this. There are general recommendations, and then comes into the specific recommendations for diagnostic radiology, nuclear medicine, and radiation therapy. And of course, I'm going to focus on the radiation therapy side. Quite a few of the aspects were mentioned on general or specific recommendations in imaging by the previous speakers. My presentation will focus on implementation of a selected number of aspects of the SSG 46 specific recommendations on radiotherapy. The ones that I thought maybe have some new aspects or would be more interesting. Radiotherapy equipment, accidents in radiotherapy, QA in radiotherapy, and a new paradigm in that. Incident learning systems, assessing safety for new technologies, and also at the end, prevention and mitigation of accidents. This will be, of course, brief because the subject area is huge. Right, now let's start on specific recommendations for radiotherapy that I mentioned. And to start with, we go have a few slides, only a few slides on radiotherapy equipment. It is said that the strength of independent verification goes like this. First of all, you have for radiotherapy equipment and radiotherapy units in particular, you should have independent verification. And if you do an IAEA postal dosimetry audit type of thing, it's the weakest, although it has a lot of benefits, but it increases the benefit increases if you use a second set of equipment, or another physicist comes and does this, or you use a different set of dosimetry equipment altogether, or different independent medical physicist comes from another organization, for example, or a national unit. In terms of dosimetry equipment themselves, of course, they have to be calibrated if they're used for calibration themselves, and they should be traceable to standard laboratories like the national SSDLs or the primary standard dosimetry laboratories. Every 2 years, once every 2 years, biennially, this should be done for this kind of equipment. But importantly, in the interim, i.e. between those 2 years, we should have regular periodic checks at our own center using check sources, for example, strontium sources, for example. But the whole procedure is fairly expensive, but it's worthwhile and includes a variety of equipment, not just the dosimeter. And in here also, there is a mention that manufacturers should minimize potential hazards from neutron activation of patients and materials in the treatment room. And in particular, we're talking about treatment linacs that exceed 10 MV. And there are publications that even at 10 MV, as you know, the use of linacs above 10 MV have reduced quite a lot worldwide due to the improvement in delivery techniques and the lack of need really for going to really high energies. But even at 10 MV, we should be careful. Okay, let's go into accidents in radiotherapy. This is a simple process map, as it's called, a process map for external beam radiotherapy. We all know this. And you have your imaging, contouring of volumes, planning, and then review, and then the treatment in different fractions. And at the end, it's they're finished. So what should we do to reduce accidents? It's recommended to introduce barriers. Barriers here means quality control procedures, and provide defense in depth, as it were, using quality control. So this your process. You should have basically quality control for each process individually, or a series of processes, as well as you know, of course, something called end-to-end testing, which you give it an input and you check that the final output is as you expected. But the end-to-end testing is complementing the individual test and cannot be used as a replacement. Another thing that's interesting, and of course it's practiced in quite a few advanced centers, but probably not in all centers worldwide, is what's called timeout. This is a procedure that the radiotherapy technologists, RTTs, should use before every expose or treat button pressing, i.e. before every beam on, that they consult, somebody says the name of the patient, positioned, correct position and landmark being used, procedure that is being used, is it correct? With dosimetrically relevant materials such as bolus, etc., have they been placed correctly? Online imaging has been done as should have been done on this particular fraction, etc. When all of this is basically okay, then the beam on is executed. And really, this is the last line of defense in this layered defense mechanism or defense in depth. Of course, everybody knows about the history of accidents and incidents in radiotherapy. They've involved numerous patients, and it is said that these accidents have been the result have caused numerous deaths. Some of them have not been really reported even. But the ones that have been reported, there are several documentations on these and things to be learned from them. Now, the causes that have been identified are interesting to look at. Incorrect commissioning by non-qualified physicists, or not having some kind of an internal or external audit after the commissioning. Incorrect repair of the accelerator, lack of reporting or non-qualified repair person caused this. Accelerator interlock failure, outdated design, incorrect design of the equipment, especially in the previous years, but not always in the previous years. Many years ago, sometimes just within the past decade or so, we've seen this happening. Miscalibration of beams, a lack of understanding and education, lack of internal, external audit. Incorrect use of TPS, treatment planning system, or record and verify system. Lack of understanding and education, again, missing one data root or risk analysis is missing. These are very helpful, of course, your record and verify system, but even they can cause problems themselves, or over-reliance on them, I should say, could cause problems. Not following procedures, lack of understanding of the procedures, or lack of familiarity with the modality, and ignoring alarms, the error messages and the alarms that are designed to warn us. Because of lack of education or training, we might ignore them. So lessons to learn and summarize all this. This is the way it says we should work with awareness and alertness, be aware of what we're doing, basically. And remembering that an irradiation cannot be undone. There is an undo button on this one, unfortunately. So whatever you do, you should do it before that. Procedures, think through if procedures are covering the right, covering what might go wrong. Training and understanding of the situation, education is immensely important, and knowing our responsibilities and defining the responsibilities, allocation, correct allocation, understanding of what everybody must do. Okay, now let's move on to QA in radiotherapy and offer a new paradigm, a sort of different look at this. Here we need to define systems or subcategorize two systems in two ways, i.e. call them complicated systems or complex systems. What are these? Complicated systems have several steps and they're not totally straightforward and easy, but they are understandable because each individual part of the system can be understood. Okay. And when you put the parts of the complicated system together, one can still understand the whole system. And so a relatively high degree of certainty of outcome repetition can be ensured. Okay. But a complex system, it is subject to several factors in a sometimes unknown way. For example, environmental relationships, interconnections, adaptive nature of the situation, these sort of scenarios. These may impact the operation and function of these systems. Complex systems cannot be understood solely by simple or complicated approaches. Okay? They're more complicated, they're more complex than that. And some level of uncertainty of the outcome remains. We can determine complicated outcomes, as we mentioned, because we know each individual section quite well. But we can only enable complex outcomes. We cannot determine them. We can specify complicated systems very well. However, on the other hand, we can only intervene in complex systems. We cannot fully specify them. Well, what does that mean? A bit more general example, and then I go into a more radiotherapy specific one. A complicated outcome may mean getting your baggage from one city to another via an airplane. A complex one is giving you a good experience in this journey, a customer experience. You see, this is much more subjective, much more complicated, much more dependent on so many variables. A complicated outcome might be designing or constructing a village or a township, whereas designing or creating a community is much more complex. Brain surgery is a complicated procedure, but health in general is a complex outcome. And putting a man on the moon is, quite hugely complicated, but bringing up a child is complex. Okay, I hope this has sort of clarified the two. Now, what does all this mean in terms of radiotherapy? QA and quality assurance, quality control have ensured that one understands each individual component of the system used. So radiation delivery devices, dose calculation algorithms, these are individual components of a complicated system. Different systems, how they interact with each other, there's a long history of using them, and we know them fairly well. However, given the continuously growing complicated nature of the different systems, it is becoming unrealistic for any one person to truly understand each of the components and their interactions. You see, each of the components themselves are becoming much more complicated. Therefore, the overall system is going from a complicated system into a complex system now. Ensuring quality requires a person to accept that many of the systems used in radiotherapy needs to be considered as a black box, unfortunately, when one does not understand all of the components. Okay, it just becomes so complicated that no one person can be totally familiar with all of the aspects in detail. So in such a complex environment, ensuring quality might then consist of determining methods to check the process of radiotherapy without having to check each individual component. Okay, going to a new way of looking at it. Well, okay, let's go back to this relatively I wanted to say simple, but it is a complicated system, but we know each step, so we call it a complicated environment, this external beam radiotherapy of a patient. However, you go to the much more advanced adaptive image guided VMAT. Now, delivered treatment to the patient is affected by several more factors and subdivisions. Prescription, position, immobilization, delineation, prescription, dosimetric planning modality, Pareto optimal plan, multi-criteria optimization. The whole thing has become so much more complicated and so much more adaptive, right? So, and also in all this, many humans and may well in future, many AI, artificial intelligence modules will have input into this, to daily imaging and all these different aspects. It's become a complex environment because each of the sections are not so well defined anymore and so well understood anymore. So the new paradigm and the new thinking says, look at it a different way. So look at the process, look at the overall sort of picture rather than individual steps. When you cannot specify the individual steps, that is. So identify risks in your process, assess risks and share across the community, monitor against tolerance and action levels, control of unacceptable conditions through defined actions, evaluate the effectiveness of the system by thorough follow-up, and then learn from what you've seen and what you've analyzed, adapt your tolerances, adapt your resource levels and approach, right? So this is a fairly different way. However, I understand and I accept that elements of this have been the backbone of quality assurance in the past, but this is looking at as a whole process a bit more. Right. So how can we look at processes in sort of more detail and subdivide them into sub-processes? We use process mapping and several ways of doing this. You identify processes which are more error-prone, either prospectively using methods such as failure mode and error analysis, FMEA, that I'll have a few slides on, or retrospectively using things like root cause analysis. Identify measures and control and measure quality of your measures or control points and share them and look at the possible places where you could go wrong via getting international advice, sharing international experience or national experience or even local. Okay. Process maps provide a visual picture of the process. I've shown you one or two of them already and show how inputs, outputs, and tasks are linked. And these identify major steps in the process and who performs each of the steps. You can, by looking at them, you can they can help understand process deviations and vulnerabilities, breakdowns, mistakes, etc. And we also know them as flowcharting. And there are numerous formats and approaches, and this is not where, I mean, there's no time here, and I'm not really an expert on this either, but we have seen them, these sort of things that you can flowchart your process, okay? Let's talk about FMEA a bit more. Failure mode and effect analysis prospectively, proactively follows a pattern, and you ask the questions that are here in each sub-process. What could possibly go wrong? Potential failure mode. How could that happen? What are the causes? What could be the causes in the future? And what effects would this failure mode produce? Potential effects of failure, right? So you divide them into this and then you create your fault tree. I will explain further. You involve all the different subgroups of staff, and for each component, You define possible failure modes, possible causes of each failure mode, consequences of each failure or adverse event, such as overdose, etc. And then use your barriers and look at how those barriers are in fact perform. These could apply to equipment, to the process, to people, and even to outside of your institution, i.e. patient transportation, for example, or a medical laboratory, that sort of thing. Okay. Now, to quantify this risk or to quantify what is, if this is quite an error-prone and dangerous activity, or this is really safe one, we need to quantify this and give it numbers. So you assign a probability or likelihood of failure that incident occurs. We call it O. You assign a number that says the severity or indicates the severity of the incident, the effects of those incidents. We call it S. And the probability of lack of detection, if you know what I mean, the probability of the failure, that the failure will go undetected, we call it D. We multiply all these three together, which gives us the risk priority number RPN, and could be that the O, S, and D are in the range 1 to 10. And of course, the highest risk priority number is where you would concentrate on doing something about, of course, as a means of improving your work. Okay, so these are O, S, and D values that you could possibly might want to use. Unlikely to inevitable in terms of occurrence. So the frequency, low to high frequency, these sort of the values. In terms of severity, qualitative, no effect all the way to catastrophic effect. And what they could mean inconvenience or very wrong dose or death, etc. And detectability or lack of probability of lack of detection going undetected. So it is sort of as of a low probability, i.e. something that's very likely will be detected, to something that's more than 20% chance of not being detected. For each step, potential failure modes are listed, assigned these values, and as I said, you go and fill up this table. So let's look at one example to maybe clarify it a bit more. Setting up a patient and delivering a treatment to an incorrect position. Okay, setup error. So incorrect ISA center, and for example, look at this, shift specified incorrectly in setup instructions. So you were supposed to shift by, I don't know, 2 centimeters, you shifted by 3 centimeters, something like that. So potential effects of failure, those delivered to wrong volume, PTV underdosage or overdosage, PTV underdosage or OAR overdosage during all fractions, because this is like a systematic change. And these are the values of O, S, and D that have been looked at, derived. This is the product of the multiplication, and then proposed actions would be training and second check of all parameters, review the methods, so that such an error, the probability of occurring it would be much lower. Okay. This detectability, this last, this D value can be quite difficult to quantify, you can imagine. So there are sort of simple ways of saying, okay, let's do this without considering detectability, only likelihood or probability, i.e., or the severity, just the product of these two. And here are, for example, likelihood or probability scales for very infrequent to very frequent. And so you could assign this kind of a scheme going from once every 10 years to once a day as being a very frequent event. And severity scale of the consequence for the patient, minor one, and a catastrophic be death, for example, as a result of that. And then when you multiply these two together, you might get a what's called a risk matrix, and you can subdivide it into sort of acceptable, a level here that's acceptable and control, no risk reduction action yet, but there is a need to control this situation, this kind of yellow area here, and then the red is unacceptable situation. You have to do something about this. And when you look, the more the severity, number 5, for example, here is in yellow, here is somewhere else, you might get 5 in the green area. See, so it depends also on the level of severity that you might accept something or not. Okay, the tools that I mentioned briefly, and I only mentioned a few of them, 1 or 2 of them, in fact, they provide the methodology for adopting quality management programs. They have potential for time and resource savings, and they focus and allow us to focus on the weakest link in the process, and to introduce barriers at the weakest point at different levels, and provide us this defense in depth that we mentioned. All of this should lead to a higher quality and safety and potential for improving patient outcomes. Okay, so other incident learning systems, something like something to share experiences, and they're not. I think the naming is interesting as well. It's not called. It used to be called accident reporting systems, but I think it's a much better interpretation to call it incident learning systems. You reported, of course, an accident, but it's geared towards how can we learn from these more. International ones exist, national ones exist, and web-based, quite a lot of them. And these are anonymous, for example, and I would like to just mention in particular the one by IAEA called Safety in Radiation Oncology, or SAFRON. But there are other ones as well, and previous to this too, or at this present moment too. Incident reporting systems, mandatory reporting systems, voluntary, internal, and external. These are the subdivisions. By law, you must report some things. Some aspects are voluntary. You might have mechanisms for internal reporting within your institution, or this could be external, to share the experience with others so that the others might not make the same mistake. This is the URL for SAFRON, the IAEA SAFRON. SAFRON is a non-punitive, there's no punishment involved. You just report it. It's anonymous, it's voluntary, it's educational, and it's for learning, and it's an international system. It isn't meant to replace your reporting to the regulatory body in your country, or to the management in your institution, and it works with other ones as well, other ones that I mentioned. And it might be interesting to see some of the consequences, some things that have so far been detected. This data is a few years back, I think, from 2021, these numbers, but the proportions are the same, or roughly the same. Question: who detected the incident for all external beam radiotherapy incidents? Okay, you have your radiation oncologists, medical physicists, etc., and you see that here the RTT, both in pre-treatment phase and in the treatment phase, have the most influence, the largest, followed by a long way, by a long distance, by the medical physicist. So an alert RTT, an alert medical physicist could reduce quite a lot of the errors. How was the incident detected? Again, for all these incidents, chart checks that are done, second checks, third checks of the patient chart, and also, for example, when at the time of the first treatment fraction or at a later stage during the treatment. This is how they were. So this is sort of gives you an idea where this detection most occurs. Right. So in terms of error detection, you have this kind of a Swiss cheese model that you do this defense in depth, and you have layers and upon layers of defense, that if something got through in the first layer, you stop it in the second. If it went through, you stop in the third, etc., etc. So and the hope is you have enough layers that almost all of these will get checked. And we call them, or they call them, consequence reducers, weekly quality control, weekly chart check, medical review, etc. These are consequence reducers, or the probability reducers in this. So if you look at all these different barriers, what barrier stopped the incident the most? I'm not sure what is happening. Somebody is drawing on my slides. I'll ask them not to do that, please. Non-clinical phase, pre-treatment phase, treatment phase, different scenarios, different statistics. Again, the barrier that stopped things the most at pre-treatment is review of the treatment plan, and then during treatment, again, is that in addition to this timeout that I mentioned. Okay, now we are in the scene that more or less centers are assigning safety, assessing, introducing new technologies of different levels, different complexities. Every center has some of these, one of the two, three, four different technologies that are planning to introduce or have recently introduced. So how do we assess the safety for these new technologies? One of the questions is what you call new? How much different should it be for it to qualify as new technology? Technology approach may be established, but if it has never been installed before, or if it's used clinical at the center, then it should be regarded as new and approached with great caution. Okay, example. You use IMRT, but you are moving to VMAT. VMAT should be considered a new technology or approach or modality. And there's a lot on this, but to summarize them, a new technology should be carefully planned and involved it should involve all subgroups of professionals in the center, in their introduction and in their progress. Verification of the treatment statistics show that is of utmost importance, and follow-up, local control, for example, toxicity control, checks of patient outcome is the bottom line after all. However, this takes a long time, but we should really be sensitive to them and particularly look out for them at the beginning of the change of the treatment to a new technology. Everybody remembers 2010, I hope, or us older people at least remember them. The year that the famous New York Times articles revealed serious errors in the US. Of course, there were similar things other places as well, and this has consequences in terms of how new technologies are introduced. And at the time, we have a journal called Middle East Journal of Cancer. Its headquarters is at our university, and I'm one of the editors in that journal. And this document at the time, from a medical physicist perspective, I gave a set of views on how should we not be totally technophilic, totally over reliant on new technologies, saying that this is a famous brand, this is made in a famous country, therefore everything is okay. Well, it's not, and it wasn't. So some a lot of level of care should be used, and judicious looking at this is recommended. And my last section is on prevention and mitigation of accidents. Only a few slides remaining. Guidance for restricting exposure in emergencies. We all know this HP10 deep dose equivalent, depth of 1 centimeter in tissue. These are, I'm just putting this as a reminder that you have in an emergency, you have to consider, should I risk my life, or what sort of decision criterion should I use? Well, this kind of is supposed to help that you should limit your HP10 to less than 500 millisieverts. Circumstances which you would benefit the others clearly, and this would outweigh the emergency worker's own risk. Or the same level for severe deterministic effects for catastrophic conditions also. But at a lower level, if your actions are going to avert a large collective dose, but not to that catastrophic level. Emergency plans are important, very important, mandatory in fact, and they should be short, concise, unambiguous, as much as you can, with drawings, as much as you can, something that you could look at first sight. In one look, you can see what you should do, and make sure that everybody knows what they're doing and practice it, etc. All right, thank you very much for your attention to this presentation. I hope it's been useful, and I would like to hand back to Professor Akhtaruzzaman for our moderator, and if there are any questions, please.
Thank you very much, Professor Amin MOSLEH-SHIRAZI. I think there is only one questions about this is the SSG 46. I think this is the one book from the IEA. I think it is a specific safety guide. So this is not the question actually. They're asking what does it mean SSG 46? And there is
Yes, these are, as far as I know, these are sort of the numbers are a sequence. So as I showed in my third or fourth slide, there are specific safety guides, several of them, but this 46 is for medical uses of radiation in diagnostic, in nuclear medicine, and in radiation therapy.
so here is a question. Can you specify if there are any new design consideration for a radiotherapy facility surpassing the recommendation of SRS 47? So normally SRS 47 is the design and planning for the radiotherapy facilities. So the participant is asking, is there any new books or new guidelines are available?
There is. Okay. There a couple of related to some extent to that, but not exactly. There are reports that are coming out from the ICRP, in fact, to do with imaging dose. There's a task group of the ICRP, imaging dose in radiotherapy. That may have some design consideration consequences, but not entirely. We know that there's new equipment like the Halcyon unit, for example, or the MR-Linac, for example, or new versions of CyberKnife, for example, with MLC, etc., 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 that may not be fully described in the report 47, and there is in fact a need for improvement on these. However, subsections are present. Sometimes people have to go even into looking at publications and papers. So what I'm saying is there is, in my opinion, there is a need for an update for the new equipment, sort of a more directive and a more informative and consolidated set of instructions for design considerations and for all kinds of things, such as this. Just the facility design isn't the only aspect, I think.
Yeah, we are behind of time. So this is the last question. So what punitive action will be taken if, for example, some error happens in the department even after repeated warning is given?
That's a good question. As you know, through the years, there have been various policies and strategies to going to sort of looking at what errors happen. If you totally go with punitive actions, and then there might be a consequence that people would hide them, they wouldn't report them. Your colleagues or your staff might not report them. So we went the other way for several years. I mean the community, it seems, so that it's sort of no, you say come and report, and there is no punitive action at all. So I think the furthest, though, the newest approach might be sort of just approach, i.e., if there's willful intent in causing harm, then there is punitive action. But if there's a simple mistake, then you should do something, train people, provide more staff, etc. This is not something, as you know, this is not something that there is a simple answer to. But the latest thinking is, if there's willful intent, do apply punitive action. But if it's just a simple mistake, try to do something to prevent it.
Thank you very much. We are 15 minutes behind. So, a special gratitude to all our speakers, Professor Hasin Azhari, Associate Professor NURSAKINAH, and Professor Amin MOSLEH-SHIRAZI for their valuable time and sharing their knowledge in radiation safety, quality in radiology, radiotherapy, nuclear medicine, even in the non-ionizing radiation environment. So basically, this AFOMP school session not only reinforced technical and procedural aspects, but the safety, but also highlights the importance of continuous education and collaboration across the borders. I hope all participants have gained valuable insight from renowned experts, making this an essential event for medical physicists, clinicians, even the allied health professionals dedicated to safe and effective radiation practices. So I would like to thank once again to the speakers and of course to the participants. Professor Jean, are you there? If you are there, do you have anything to say?
I am here, Akhtar. Thank
okay,
you.
Mary, Dr. Mary, yeah. Please.
Thank you so much
for the concluding remarks.
Yes, thank you so much for organizing this AFOMP school so well and successfully. I would like to thank you, Professor Anupam, Professor MOSLEH, and Dr. NURSAKINAH for your excellent talks and sharing new information and new knowledge to the participants. Thank you so much. And I would like to thank all the participants who have participated and posted questions. Thank you so much to everyone. Looking forward to meeting you all in the upcoming webinars of AFOMP 2. Best wishes. Thank you.
Thank you very much.
Thank you.